Welcome, everyone. Thank you for joining us. My name is Jackie Weiss, and it is my pleasure to welcome you to this Euroimmune Academy webinar on prenatal and postnatal testing for cytomegalovirus infection, current diagnostic strategies and recommendations. In this webinar, we will have two speakers followed by a live Q&A session. If you have any questions for our speakers at any time, please type them in the chat box on your screen. If you're interested in claiming PACE credits for this webinar, it is important that you log on individually and stay for the entire duration of the webinar, because this will be counted as your attendance. After the webinar, you will also receive an email on how to claim your PACE certificate. Without further ado, it is my pleasure to introduce you to our first speaker, Dr. Mark Schleiss. Dr. Schleiss is professor of pediatrics at the University of Minnesota Medical School, where he holds the American Legion and Auxiliary Heart Research Foundation chair. His laboratory has studied CMV vaccines for over 30 years in preclinical models of congenital CMV transmission. He also is an active investigator in human clinical trials of CMV vaccines. His research has demonstrated the utility of dried blood spot testing in a longitudinal newborn surveillance study of congenital CMV in Minnesota. Through his advocacy work, he spearheaded the drive to add universal congenital CMV testing to the routine newborn screening panel in Minnesota. He is recognized as an international leader in CMV research and clinical care. Dr. Schleiss, we are all looking forward to hearing more about congenital CMV infection. Now I will pass it over to you to begin your presentation.
Hello, thank you all for being here today. It's a pleasure to be able to speak to you about congenital cytomegalovirus infection. We'll spend the next 30 minutes or so talking about CMV, as the cartoon on this slide shows, a virus that's very important as a cause of disability and long-term neurologic and neurodevelopmental sequelae in newborn infants. So we'll talk a little bit about emerging concepts in the field, what's new in CMV by way of screening, testing, evaluation, therapies, and interventions. And I want to just report that I do receive research support from Moderna vaccines, but no personal honoraria. So we'll review the epidemiology of congenital CMV, talk a little bit about the virus itself, and how it exhibits its pathogenic effect on infants. Talk about patient presentation and some of the controversies in how we define a case of symptomatic versus asymptomatic congenital CMV. That distinction is quite important, actually, because it speaks to not only patient management, but also long-term neurodevelopmental sequelae risk. And then we'll talk a little bit about new developments in vaccines for CMV and screening approaches for CMV. So what is cytomegalovirus? The translation of the word actually means big cell, cytomegaly. And this virus was first identified actually by pathologists in the late 1800s. Of course, that was long before viruses were formally discovered as such. But pathologists saw these very large so-called owl's eyes inclusion bodies. And so this is one of the characteristics of CMV. It's a herpes virus, member of the herpes virus family. And although the genome of CMV was sequenced in the late 1980s, there's still a lot about the virus we don't understand. Like any herpes virus, though, it does cause lifelong infection. Most people during their lives do acquire CMV infection, but the epidemiology varies a lot around the world. In sub-Saharan Africa, parts of Latin America and Asia, the prevalence of CMV antibodies in people by the time they reach early adulthood is greater than 95%. It's a little less prevalent overall in the United States and Europe. And that's important, actually, because we believe that the greatest risk to a newborn infant is acquiring CMV infection before birth in the context of a mom who has the very first infection of her lifetime, a primary infection. And this is just for interests in terms of the pathogenesis of the virus. We know that this is actually the largest virus that infects people, both in terms of the size of the virus particle, as well as the size of the viral genome. And so you can see this unique long region of the genome bracketed by a unique short region. And I just mention this because it's of interest that many, many genes encoded by the CMV virus are important in evading the host immune response. And so that is problematic because you say, well, how can you create a vaccine that's better than natural immunity? But that's probably what we need. The outer envelope of the virus, as shown in the left side of the cartoon, has all of these proteins that are encoded by the virus. And these are targets of host immune response that have been the cornerstone of vaccine development for 30 or more years. This is an example of a baby with symptomatic congenital CMV infection. Of course, this is just the tip of the iceberg. As I'll come back to in a few minutes, most babies born with CMV are actually asymptomatic at birth. But these are the extreme cases that you see that have very, very severe illness. Babies that have these large spots, we call this a blueberry muffin rash. They are born with enlarged liver, spleen, hematologic abnormalities. Tragically, very often born with microcephaly, and they are at very high risk to go on to develop mental retardation and sensorineural hearing loss. Of the just under 4 million babies born in the United States every year currently, we think about 5 per 1,000 are born with congenital CMV. So that's roughly 20,000, 19 to 20,000 cases a year. And as I've alluded to, the baby I showed you in the previous slide is really just the tip of the iceberg. It's one of the 10% of babies that have symptoms at birth. 90% of babies are asymptomatic at birth. This becomes actually a driving force behind the idea of universal CMV screening, because we know a lot of these babies, even if they escape detection in the newborn nursery because they have no clinical findings, still go on to develop hearing loss. And in this landmark paper by Nance and Morton in the early 2000s in the New England Journal of Medicine, looking at all causes of hearing loss in children, you can see that CMV holds the position of being the most common single identifiable cause of hearing loss in newborn infants and young children. In fact, CMV causes more hearing loss than Haemophilus influenzae type B or even congenital rubella syndrome, the German measles, did before we had vaccines. It's important that we raise awareness about CMV. This is Katie Tastad, a graduate student I mentored a few years ago, in which we did a survey to ask pregnant persons and young adults, would they want to know about CMV if there was a screening test available? And in fact, most people do want to know about CMV, but the awareness is very low. If we look at all of these identifiable causes of injury in a newborn infant, from influenza to Down syndrome to fetal alcohol syndrome to Zika virus, you can see by the blue and gray bars that most people have heard of these things. But in fact, add all of these together and it's still fewer cases than are caused by CMV every year, and yet CMV is down at the bottom of the list in terms of public knowledge and awareness. So about 1 in 200 babies, we think, are born with CMV infection in the United States. The timing of infection during pregnancy is quite important. The risk of transmission is particularly high from mother to fetus in the setting of a primary maternal infection. And these are often pregnant people who have toddlers in group daycare. And toddlers in group daycare bring CMV home from the daycare center. Daycare centers are a great repository for circulating viral infections of all types. And in fact, if CMV is transmitted to a mom, often during her second pregnancy with a toddler in daycare, then if that's the first infection of her lifetime, that can be quite serious. Natural immunity doesn't protect completely against CMV transmission to the fetus, but it does decrease the likelihood of infection and the likelihood of injury. We also know that the timing of infection is quite important, and that most babies who do have long-term neurologic sequelae, or as the graph shows, sensorineural hearing loss, most babies are infected in the first trimester of pregnancy, and that's when the greatest injury to the developing fetus occurs. Brain development follows a pattern during pregnancy of initial formation of the brain, followed by the sculpting and shaping of the brain. This is a process that we call neuronal migration. And then at full term, the brain, of course, just like an adult brain, has lots of folds and bends, gyri and sulci, as we call them. And so polymicrogyria, which translates into simply there is a lack of gyri and sulci, is quite a worrisome sign, and it's often associated with these first trimester infections. And so a smooth brain is never a good thing, but that is a worrisome finding and often speaks to an early gestation infection. So I've already alluded to the fact that most babies are born asymptomatic, but we think it's probably a spectrum and not binary. In other words, of the 85% of babies that are born with no apparent signs or symptoms at birth, we know that up to 15% of those babies will go on to have hearing loss, even if they pass the newborn hearing screen, and that's really a critical point. Up to 75% of babies that are destined to have hearing loss from congenital CMV pass their newborn hearing screen. So we can't rely on the newborn hearing screen as a way to detect CMV-associated hearing loss risk. And so there are probably mild cognitive delays, learning issues, neurodevelopmental issues that we just simply haven't identified in the past because we don't do universal screening. Currently, we break CMV up into these categories: moderate to severe symptoms, those are the babies that we identify at birth; babies who have mild symptoms; babies who have no symptoms at all, but have hearing loss. That's kind of a special category in its own right. And as I've already alluded to, those babies may not have hearing loss at birth. And then asymptomatic babies. And so there's always a lot of discussion among pediatric infectious disease physicians and pediatricians about which babies do I treat with antiviral drugs. And right now, our state of understanding is that the only babies that acquire long-term benefit from antivirals are the ones in this first category, moderate to severe symptoms. And this is just a summary of the disease categorization criteria that come from this paper in Lancet Infectious Diseases a few years ago. These are currently being discussed and constantly revised. And so clinicians in the audience today who encounter a baby with congenital CMV, particularly if you practice in a state where universal screening takes place, can always consult with an infectious disease physician to talk through the possibilities of whether antiviral drugs would be a benefit or not. And speaking of antiviral drugs, I do want to give a shout out to Gertrude Elion, one of a disappointingly small number of women who have won the Nobel Prize for physiology or medicine. We need more women in science, but she was a pioneer in the development of antiviral therapy, and she was the one who really discovered the antiviral effect of a compound or chemical that we use all the time now in clinical practice. That drug is known as acyclovir. Subsequent work in the late 80s extended her observations to a drug for cytomegalovirus, namely ganciclovir. And the brilliant thing about this work, the thing that won Dr. Elion the Nobel Prize, was her discovery that the drug is only active in a cell that's infected with the virus. The drug has a homology to guanosine, a building block of DNA, but for it to be taken up into the DNA chain and inhibit polymerases, it has to be phosphorylated by a viral enzyme. And so this was the sort of the beautiful and elegant selectivity of the drug that led it to only really work in the very cells that you wanted to attack, namely the cells that were infected with the virus. And for CMV, the name of the gene is the UL97 kinase that phosphorylates the drug to an active triphosphate form, as you can see in the cartoon. And that's what inhibits the viral polymerase and leads to an antiviral effect. So we know that antiviral treatments for congenital CMV that could include both intravenous and oral formulations of ganciclovir are indicated for babies who have severe illness. or life-threatening disease. These are standard of care, we think, in babies who have moderate to severe symptomatic disease, as I've already alluded to. We know from this landmark study by Kimberlin et al. That 6 weeks of valganciclovir followed by an additional 4.5 months, so total 6 months duration, compared to the crossover group that was randomized to placebo, led to improved hearing outcomes and improved neurodevelopmental outcomes at 2-year follow-up. So this is a very important part of our armamentarium for the treatment of symptomatic congenital CMV. But we, again, limit this just to the babies who have severe symptoms at birth, including central nervous system involvement. Of course, now we're identifying babies with asymptomatic CMV, as I've already alluded to. And so what's the basis for screening all newborns for CMV? Those that work in the newborn screening field often cite the classic work of Wilson and Younger that define whether or not a diagnosis should be screened for in newborn infants. It needs to be an important condition that can easily be missed without a screening test. You need to have a suitable screening test. Ideally, you have a treatment and you have a cost-effective management strategy that improves the outcome for the baby. And it remains debated whether or not CMV falls into this category, chiefly because of the screening test. We can screen newborns for CMV based on whether or not they pass or fail their newborn hearing screen. That's so-called hearing targeted screening. But I think the field is moving more toward universal screening, simply because, again, as I've alluded to, many babies pass their newborn hearing screen only to go on to have hearing loss later, 2-3 years of age, in many circumstances, from congenital CMV. So how do you do universal screening? You need a good test that can reliably identify the diagnosis. And so this is a controversy in the field. How do we identify this? There's a lot of appeal toward using the newborn dried blood spot because, after all, it's collected on all babies to screen for various genetic and metabolic diseases. But the sensitivity of the test to identify CMV is probably no better than 80% in the best case scenario. And so it remains uncertain whether or not this is an approach that will be embraced by the recommended uniform screening panel, so-called RUSP, the thought leaders who drive newborn screening decisions. So moms, parents, activists, advocates have said, let's take matters into our own hands. Let's use the legislative process to try to develop newborn screening, which is really quite revolutionary in the newborn screening world. This first legislation passed over 10 years ago now in Utah, said that in any baby that fails the newborn hearing screen, they should be tested for CMV. The section on infectious diseases in this publication at the time had some very pointed comments that were important and need to be considered as we see other states now moving forward with CMV screening. Most significantly, this issue of off-label use of ganciclovir. Other experts have also opined that screening for congenital CMV may create a scenario in which the risks outweigh the benefits because of the risk of the vulnerable child syndrome. If 80% of babies with congenital CMV are destined to have a normal outcome, then do we unnecessarily raise concern and anxiety in families for only the 20% that will have some long-term issues? And so this is an issue that's much debated. Here in Minnesota, we took this into our own hands. Actually, a patient of mine, Vivian Henriksen, and her mom and I went down to the state legislature about 7 years ago now and began the process of thinking about what a newborn screening bill might look like in Minnesota. And we had success. We had newborn congenital dried blood spot screening commence early this year in Minnesota. And so we're dealing with the very issues that we anticipated could be problematic, namely what to do about the asymptomatic baby, what to do about the use of antiviral therapy in asymptomatic infants. But I think overall, we've done a good thing, and we've helped children by doing this. As you can see in the left part of the slide, Minnesota is the state now that has universal congenital CMV screening. Connecticut just passed legislation this summer to begin a universal congenital CMV screening program by the year 2025. And New York State has a research protocol in which they're screening newborns for congenital CMV in New York State as well. This is something that has been standard of care in Canada for several years, first in Ontario and then more recently in Alberta and Saskatchewan. Interestingly, newborn screening for CMV in those Canadian provinces is not under the aegis of the newborn screening programs, but rather conducted by the early hearing detection and intervention units in those state governments, so-called EDI. It will be interesting to see how this issue continues to evolve over the next few years. But at this point, Minnesota is the only state in which we have universal screening. We have a lot of challenges as we begin universal congenital CMV screening in Minnesota. What to do if an infant has a normal history and physical exam? How much of a laboratory and neuroimaging workup do they need? We worry about the politics of newborn screening. There are some forces in the political space who think that this is an area of personal privacy and that we may be doing harm through the vulnerable child syndrome, as I already alluded to. How much of a concern do we have to have for long-term neurodevelopmental outcomes in asymptomatic babies? And I've alluded to the vulnerable child syndrome already and the risks of creating undue anxiety. And then finally, we do worry about ganciclovir or valganciclovir being used in asymptomatic babies. There's already evidence that came out from some authors at the CDC last year that compared the percentages of prescriptions being written over the last 15 years or so for valganciclovir and saw, as you can see in the graph, striking increases in the total amount of prescription of valganciclovir. And that's not because the epidemiology or clinical manifestations of congenital CMV has changed. I think it's because clinicians are eager to try to help their families, but they're prescribing the drug without good evidence of benefit. What about CMV screening during pregnancy? We'll hear more from my colleague in this webinar today about IgG avidity testing. The challenge with maternal screening during pregnancy is what to do about pregnant persons who have CMV antibodies. In other words, they're immune to CMV, they've had CMV infection, but they might be at risk for reinfection with a new strain of virus. And since reinfection with new strains can lead to transmission to the fetus and disability for the newborn, it's not recommended that we do universal screening for congenital or for maternal CMV antibodies during pregnancy. It is, however, an area that's being considered in Canada, where screening is more commonly offered, especially in the first trimester, in provinces where there is IgG avidity testing available. So that's really an important point of today's webinar, is that it's not just a question of whether you're IgG positive for CMV, but how avid are your antibodies? What's the antibody avidity? And so the American Congress of Obstetrics and Gynecology in the United States currently doesn't recommend maternal CMV screening in pregnancy, but that's a recommendation that may evolve in the years ahead. Finally, I want to finish the presentation today with just a few words about the current state of cytomegalovirus vaccines, a question that I'm asked quite frequently. Of course, a CMV vaccine could be something that could be envisioned for many patient populations. We haven't had time today to really speak about the impact of CMV in solid organ transplant patients or patients with HIV infection. And we know that CMV is an important cause of disease and morbidity in those populations as well. But the major emphasis for CMV vaccine development currently is to protect the newborn infant against congenital CMV, in particular against congenital CMV-associated adverse health outcomes like hearing loss. And so again, I've shown you this slide already, but this is a blown up version of what the virus particle looks like. And most of the work over the years has focused on this major protein that is in the envelope of the virus, the glycoprotein B. As you can see here in the cartoon, it forms a trimeric configuration that helps the virus stick to the cell and enter the cell. Now, more recently, we've also seen a lot of activity with what's called the pentameric complex, or PC. These are the cornerstones of subunit vaccine development. Just as we immunize with a spike protein-based approach to protect against COVID, so too are investigational studies examining these particular CMV protein subunits to protect against CMV infection and disease. These studies are a high priority. The Institute of Medicine identified a CMV vaccine as the top priority for this century. And when you think about it, that makes sense because it's really all about cost-benefit analyses. If you can protect a child against a lifetime of disability, hearing loss, mental retardation, developmental delay, then that actually has an enormous economic impact, not to mention a personal and social impact. So CMV vaccine research has been ongoing since the 1970s, and many of them have been evaluated with not tremendous success. But we've seen a renaissance in CMV vaccine activity just in the last 5 years, including the novel mRNA-based platforms that we know were so spectacularly successful for COVID-19. These are now underway for CMV, including a phase 3 efficacy study that data should be available from in the next year. And so this is an mRNA-based vaccine, and it's being given to women of childbearing age to see if they're protected against acquiring CMV infection. And after all, if a woman does not catch CMV, does not acquire CMV infection, then by definition, it can't be transmitted to the fetus. So this is a global study, and we're all very excited to see what this data show. Now, there's also another approach called a disc virus, DISC, which is a replication-disabled form of the whole CMV virus particle. These data are now published, and there was some suggestion of benefit in that vaccine as well. It remains to be determined what the future of that vaccine will be for subsequent phase 3 studies or eventual licensure. And then finally, just as we've seen with the COVID story, so too with CMV, we are seeing not only messenger RNA-based platforms, but protein subunit platforms. And there is a protein subunit vaccine that is currently in clinical trials. In phase 1 studies, I think the enrollment now has been completed, and we're very eager to see what the immune response was to that vaccine. And that's based on that GB and pentamer that I showed you in the cartoon a couple of slides ago. And there's lots of other activity in the CMV vaccine landscape, ranging from replication defective viruses to viruses that are vectored using vaccinia virus Ankara, recombinant protein subunit vaccines, peptide vaccines, DNA vaccines, and as I've already alluded to, the RNA vaccine platform. And so it's a very exciting time to see CMV vaccine development. And as we've seen now with the development of a RSV vaccine, including an RSV vaccine that's indicated for pregnant people at mid-gestation to try to protect the newborn against RSV disease, I think it's a very exciting time to be in vaccine discovery for vaccines that might work in the maternal neonatal space to protect newborns in particular. Well, that's the presentation, and I want to thank you all for your attention, and you can feel free to reach out to me at any time. And I also want to acknowledge my many, many collaborators at the University of Minnesota, the Minnesota Department of Health, funding from the CDC and the NIH, partnerships with the children's hospitals in Minnesota. This is a recent photograph of my lab team. And finally, I thank all of you for your attention today and look forward to hearing your questions.
Dr. Schleiss, thank you so much for that wonderful presentation on congenital CMV. It is my pleasure to introduce you to our next speaker, Dr. Harry Prince. Dr. Prince recently retired from Quest Diagnostics after serving as Scientific Director for Infectious Disease Serology for 26 years. His responsibilities included oversight of infectious disease antigen and antibody assays, technical consultation with clients, and assay development and validation. His experience in CMV, IgG, avidity assay development and interpretation spans more than 20 years. Now, I would like to welcome Dr. Prince to begin his presentation on the role of IgG avidity testing for the diagnosis of primary CMV infection during pregnancy.
Good morning or good afternoon. My name is Harry Prince. Approximately a year ago, I retired from Quest Diagnostics in San Juan Capistrano, California, where I served as the Scientific Director for Infectious Disease Serology. I'm enjoying retirement, but I'm happy to talk to you today about the role of CMV IgG avidity testing in diagnosing primary CMV infection during pregnancy. Much of the information that I'm going to be sharing with you today was published several years ago now. This article by myself and my colleague Mary LePay Nixon appeared in Clinical and Vaccine Immunology in 2014. And as Dr. Schleiss indicated in his presentation, the issue or problem, if you will, that we're focusing on today is congenital CMV infection. Just a brief review, this affects about 40,000 newborns in the United States on an annual basis. The clinical manifestations are hearing loss, visual impairment, and cognitive defects, among other things. It's been determined that the risk of congenital infection is really strongly linked to maternal primary infection. So upwards of 40% of babies born to mothers who acquire a primary CMV infection during conception will go on to exhibit congenital CMV infection. In contrast, if the mom has been infected before conception, in other words, if she's positive for CMV IgG, the chance of the baby having a congenital disease is only about 1%. So you can see that identifying pregnant patients with a primary CMV infection is an important component of maternal and neonatal care plans. How do you identify primary infection in pregnant women? The best way is to document seroconversion. However, this is rarely effective because of the lack of preconception antibody testing to identify seronegative women before they become pregnant. Another tool that's been used in the past is detection of CMV IgM. This is a really sensitive test for primary infection, up to 100% sensitivity. The problem is that the specificity is really poor. Only about half of IgM positive individuals actually have a primary infection. And we'll go into why that is the issue in a couple more slides. The third option, in which we're going to talk about here, is CMV IgG avidity testing. This is both a sensitive and a specific marker for primary infection and is now considered the gold standard for distinguishing primary from non-primary CMV infection. So the goals of this presentation are fourfold. First of all is to define avidity and the basic methods we use to detect it, to summarize published results demonstrating the utility of avidity assessment during pregnancy. Then we're going to discuss the commercially available IgG avidity assays out there. And finally, we're going to go over some of the issues and controversies in diagnosing primary CMV infection during pregnancy. So what is avidity? Avidity is the aggregate strength with which a mixture of polyclonal IgG molecules bind to multiple epitopes on a given antigen. Okay. Avidity gradually matures over several months. And this reflects the antigen-driven selection of B cells that produce IgG of ever-increasing affinity. Now, so the IgG antibodies that are produced during the first few months after infection bind weakly to antigen. In other words, they exhibit low avidity, whereas those antibodies produced by 6 months post-infection will bind tightly to the antigen. In other words, they exhibit high avidity. The basic methodology that's used capitalizes on the weak binding of low avidity IgG to the antigenic epitopes. These low avidity IgG molecules will dissociate from the antigen in the presence of a mild protein denaturing reagent. The one that's most commonly used is urea, but there's also a couple of assays out there that use either potassium thiocyanate or guanidine chloride. And the most common format is an ELISA. Now, this next slide exhibits what you would expect for a sample that exhibits high avidity. The high avidity molecules are in sort of a pinkish color, whereas the low avidity antibodies are in blue. So we add the patient sample to 2 different wells, well 1 obviously and well 2. And all of these antibodies, both the high avidity and the low avidity antibodies, will bind. Well 1 is subjected to a regular wash system where all of the antibodies still remain attached to the antigen. And that will give us an optical density value in the ELISA readout in this example of 2.1. Whereas the second well, instead of washing with regular wash buffer, we're going to wash with buffer that contains urea, typically in the 4 to 6 molar range. What will happen then is that the low avidity molecules, the ones in blue, will dissociate, leaving the high avidity molecules still bound. So your optical density value will be just a little bit lower, in this case 1.5. We then calculate an avidity index, which is referred to as AI in some of the slides that'll be coming up. And this is just a calculation where we divide the urea wash OD by the regular wash OD. In this situation, that would be 1.5 divided by 2.1 to give us a value of 0.71. And many laboratories report this as a percentage rather than 0.71. So the reported result would be 71%. The avidity result would be 71%. Now the next slide shows us an example of a low avidity result. You can see here the same sort of thing, only the majority of the antibodies here are low avidity antibodies. Again, during the regular wash, none of the antibodies will dissociate. So we still get our OD of 2.1. But in well 2, where we subject the well to the urea wash, all of these low avidity antibodies in blue will dissociate, leaving only the few high avidity antibodies still binding. That gives us an OD of 0.6. And thus our avidity index is going to be 0.6 divided by 2.1, or 0.29, which is 29%. The interpretation of your antibody index, though, must be established for each and every assay that's out there, the ones you develop, the ones that are commercially available. For an example, a low avidity assay is typically defined as a value of less than 50%, somewhere it can be 40% in some assays, 60% in other assays, but a general rule is less than 50% is considered low avidity. Now, a narrow range of, say, 50 to 60% is interpreted as intermediate avidity, and then a value greater than 60% is considered high avidity. Now I want to go over some of the core publications that led to the determination that avidity is a really valuable tool in identifying primary CMV infection during pregnancy. These are all labs that are in Europe, Belgium, France, Germany, and then 2 in Italy, Pavia and Bologna. Okay. All 5 of these centers used very similar protocols. They had a primary infection group that was documented by seroconversion or virus isolation. a past infection group, which was IgG positive but IgM negative, a CMV reactivation group, which are people that had been infected for more than a year but were still IgM positive as well as IgG positive, and then the at-risk group of pregnant women whose first prenatal sample was positive for both CMV, IgG, and IgM. And then the readout, if you will, was the monitoring of pregnancy outcomes to identify congenital CMV transmission. There are a few major findings that I'd like to summarize for you here from these publications. The first finding is that CMV IgG avidity distinguishes primary from past infection very, very clearly. In all of the groups, the average avidity index in the primary infection group was somewhere in the 15 to 30% range, whereas the average avidity index in the past infection group was much higher in the 60 to nearly 90% range, depending on the assay, depending on the lab. The percentage of primary infection individuals that had a low avidity index was really high in 3 of the 5 groups that actually presented the information, somewhere close to 90% or more. And the percentage of past infection individuals who exhibited high avidity was also high, greater than 90%. So this showed that avidity clearly distinguished the primary infection group from the past infection group. The next major finding was that due to the gradual maturation of avidity over time, avidity can be a useful tool in determining the time since infection. Most pregnant women showed, with a primary infection, showed low avidity for about 3 months, intermediate avidity for months 4 or 5, and high avidity at greater than 6 months. And this is a picture, a figure, if you will, from one of the groups demonstrating the low avidity, intermediate, and high avidity groups and how the maturation occurred over time. So the take-home messages from here are that high avidity during the first trimester indicates infection more than 4 months earlier, that is, before conception. So the risk of vertical transmission is quite low. The other take-home message is that low avidity during the 3rd trimester clearly indicates infection after conception. And so those women will be at higher risk for vertical transmission. The third major finding was that avidity is an effective tool for assessing the risk of transmission. This is the data sets from 2 of the labs, Brussels and Bologna. You can see that women in the low avidity group had transmissions in the rate of 20 to 30%, whereas individuals in the high avidity group had transmission rates in the single digits, and a total of 10 here. And interesting, in all 10 of these transmissions, avidity testing occurred more than 3 months after conception, in other words, after the first trimester. So again, the counseling implications here are that high avidity during the first trimester indicates a low risk of fetal infection and invasive procedures are not needed. High avidity, when initially tested during the 2nd or 3rd trimester, cannot rule out primary infection after conception. So you need to monitor for signs of intrauterine transmission. And low avidity results, regardless of the trimester, should trigger further testing to assess fetal infection status. And the 4th finding here is that CMV avidity is better than CMV IgM for identifying recent infection. And that's because greater than 50% of individuals that are positive for both IgG and IgM, this represents non-recent infection. In other words, they exhibit high avidity. Here are results from a few different labs showing that of the number of IgG positive, IgM positive subjects, the number with high avidity ranged somewhere in the 50 to 60% range. Why is this? Why is this going on? The poor specificity of IgM represents a couple of things. One is that the IgM may be produced during reactivation or reinfection with a different strain. But by and large, the most common explanation is long-term persistence of IgM following CMV infection. This is persistence for up to a year and occurs in about 25% of seroconverting pregnant women. To demonstrate this, I have a hypothetical clinical case here where we have a woman whose first prenatal serum was collected at 12 weeks of gestation, and testing showed it to be positive for IgG and IgM. If this woman shows a non-persistent IgM pattern, which I'm going to call pattern A, this indicates recent infection after conception with an increased risk of congenital infection. However, if she exhibits persistent IgM, in other words, pattern B, this would indicate non-recent infection prior to conception and a low risk of congenital transmission. So how do we distinguish between these? We measure IgG avidity. And this is a slide that sort of puts that all together. This slide shows the timeline for this theoretical patient where we're looking at all the serologic markers following primary infection. Again, so this patient is G positive, M positive, and has an IgM relative signal of 20, where the reference range is less than 5. So when we go to our graph, if we look at the green line, which is representative of IgM pattern A, in other words, not long persistence, the 20 correlates with a time post-infection of around 2.5, 2 3/4 months. That is within the 3 months post-conception that this individual shows. I remember she was tested at 12 weeks post-conception. So this would indicate that she was infected soon after conception, and thus the fetus would be at high risk for neonatal infection. However, if this patient exhibits persistent IgM, in other words, pattern B shown here in the red line, a 20% value would correlate with infection at greater than 6 months previously, well before conception. This would indicate that the risk of vertical transmission of CMV is quite low. But of course, it's impossible to tell from a single serum sample if this patient exhibits IgM pattern A or IgM pattern B. How do we distinguish what's going on here? We measure the IgG avidity. Luckily, and I like to think in this hypothetical case, the individual showed an avidity value of somewhere around 70%, which would indicate high avidity, which means she was infected well before conception and there's very low risk of transmission. However, the CMV IgM index can provide clues to the expected avidity result. This is a study from workers at the CDC published in 2011, which showed that the higher the IgM index, shown here on the x-axis, the more likely the avidity index is going to be low. And in my lab, in conjunction with a colleague at another Quest facility, we looked at this as well and found that individuals that had an IgM index considered very high, greater than 4, 100% of them had low avidity. And as the IgM index decreased, the proportion that had low avidity decreased as well. Now let's move to a examination of some of the commercially available IgG avidity kits. As you can see, there's many that are available from different vendors around the world. Most are ELISA-based, but a few use other technologies like chemiluminescence or fluorescence. The vast majority use urea as a dissociating agent. The avidity scores are similar, but show some variation, and high avidity scores also. Some of these can be purchased in the United States, but only as research use only designations. the point that I'd like to focus on here is that there are no avidity assays available in the United States that are FDA cleared. This shows the accuracy for diagnosing recent or non-recent CMV infection by some of these assays that are commercially available. We're looking at the receiver optic characteristics area under the curve, and the recent infection ROC analysis shows values anywhere between 0.6 and 0.78, which is actually quite good. And in the non-recent infection group, again, quite nice values, one slightly low at 0.5, but most in the 0.7 to 0.8 range. So again, demonstrating that they all perform pretty well in distinguishing primary from non-primary infection. What are some of the issues and controversies? One is, how should those intermediate avidity results be interpreted? Now, roughly somewhere between 10% to 20% of at-risk pregnant women, in other words, those who are G positive, M positive, but have an unknown time of infection, exhibit an intermediate avidity result. And this is consistent across 10 different publications. Now, when you analyze all study participants, congenital transmission rates for intermediate avidity group are similar to the rates for your high avidity group. It's, for example, here's a nice example. The low immediate avidity group showed 32% transmissions, whereas the intermediate avidity group had a value of 4% transmissions, which is very similar to the high avidity group. So that's pretty encouraging. However, again, this was from one of those 5 core labs. If you interpret the immediate avidity result, depending on the trimester when the avidity was measured, you see a slightly different story. This is again from the Lazzarotto group. You can see that if the sampling was done in the first trimester, you see what we saw on the previous slide. The percent of individuals showing transmission, mothers showing transmission, is really low at 3%. But if the intermediate avidity result was on a sample collected in the second trimester, that value is 23%, much more similar to the value seen in the low avidity group, indicating a higher risk of transmission. So the counseling message here is that intermediate avidity in the first trimester is comparable to a high avidity result, indicating low risk of fetal infection, but intermediate avidity in the second trimester is comparable to low avidity, indicating increased risk of fetal infection. Another issue or controversy is, should CMV avidity be measured only for samples that are positive for IgM? In multiple studies, more than 95% of sera with a low IgG avidity were IgM positive. However, in all studies that have been published where IgM positive and IgM negative samples were tested for avidity, somewhere up to 3% of samples showed a low avidity result. And intrauterine transmission of CMV infection has been documented in pregnant women who were positive for IgG only, in other words, negative for IgM, but who nevertheless had a low IgG avidity result. So the suggested testing algorithm is a pretty straightforward one, show here. You would test first for both CMV, IgG, and IgM, and if the IgG and IgM are negative, you don't need to do any further testing. If the IgM is positive but the IgG is negative, there's no point in doing IgG avidity testing because then there isn't any IgG there to measure the avidity of. But these two groups, G positive, M negative, and G positive, M positive, should be further tested for IgG avidity. And a third controversy is, should all pregnant women be screened for evidence of primary CMV infection? There's pros and cons. Let's go through the cons first. First, is currently not recommended by any national government to screen women for evidence of primary CMV. The reasons for this include unjustified pregnancy termination due to patient anxiety, lack of interventions proven to reduce or prevent transmission even if you find primary infection, and inability of screening programs to identify the small percentage of women who are G positive before conception, but who nevertheless transmit CMV to their babies. However, there are pros for screening all pregnant women for evidence of primary CMV infection. The main one is that it allows you to deliver very powerful counseling messages if the screening is done within 2 months of conception. If the sample tested is negative for G and M, you don't need to do avidity. The message from the standpoint of counseling should be take measures to reduce your chance of infection. This means avoiding contact with children's body fluids and washing your hands frequently. If the result is IgG positive but IgM negative, you usually don't need to do avidity testing. This nearly always indicates past infection with a low risk of vertical transmission. You would only measure avidity if it's clinically warranted. If the sample is positive for both IgG positive, if the sample is positive for both IgG and IgM, and the avidity result is either immediate, intermediate, or high, and again, this is within the first 2 months of conception, this indicates that infection occurred prior to conception, most likely, and thus there's a low risk of vertical transmission. However, in these G positive, M positive patients, if the avidity is low, this indicates that infection with conception was likely, and the increased risk of vertical transmission exists, but it isn't a foregone conclusion. And then you can discuss additional testing options with the patient. And in the rare situation where the sample is positive only for IgM, again, this indicates that avidity testing should not be done. The infection is very recent, and the same message that you deliver for low avidity should be delivered to these patients, and you should definitely follow up these patients to document seroconversion, in other words, the development of a positive IgG result. So in summary, CMV avidity testing is a proven, valuable laboratory tool for diagnosing primary CMV infection during pregnancy. Low avidity, regardless of trimester, indicates infection within the previous 3 to 4 months and increased risk of fetal infection. High avidity, and usually intermediate avidity during the first trimester, essentially excludes infection after conception and indicates a low risk of fetal infection. Intermediate or high avidity during the second or third trimester does not rule out infection after conception, and additional tests to assess fetal infection may be needed. And lastly, maximum detection of primary CMV infection requires IgG and IgM testing, followed by avidity testing if the IgG is positive. And with that, I thank you for your attention.
Thank you both for your wonderful presentations. You have covered many interesting and important topics in the field of CMV testing. I would also like to thank everyone who has submitted questions. We will now begin the Q&A session. If you have any questions for our speakers, please type them in the chat box now. If your question does not get answered, we will get back to you via email. I will direct questions to whomever was speaking when the question was asked, but please feel free to add your input even if the question wasn't directed to you. Dr. Schleiss and Dr. Prince, I will now begin with the first question. This question was directed towards Dr. Schleiss. Are there initiatives to increase awareness of congenital CMV?
Yes, I mean, there certainly are. And one of the major initiatives that we're seeing unfold right now is in the United States Senate. There's a piece of legislation that is working its way toward committee. evaluation, it's seeking a sponsor, a second sponsor, and it would earmark some funding from NIH to increase awareness at the national level. There are also a lot of initiatives at the state level, individual state level. And so Minnesota is one such state. I've commented in my presentation on legislation to move forward universal screening, but many of these bills also have knowledge and awareness components in which funding is set aside to earmark resources for educating the public and obstetricians about CMV. CMV should be preventable. Simple hygienic precautions, particularly in individuals in households where there's intense intimate exposure with young children who might be shedding virus acquired in group daycare centers. Just meticulous hand washing, care with body fluids and secretions. All of these initiatives are going to move the field forward. Richard Blumenthal, who's a senator from Connecticut, is working on this at the national level. I would also refer the audience to the National CMV Foundation. They have a terrific website with tremendous resources and links to different kinds of initiatives that are promoting awareness.
Great, thank you for that. Okay, Dr. Prince, are direct detection methods ever used instead of or in addition to serology in pregnant women? Oh, I believe you may be muted, Dr. Prince.
Sorry.
No problem.
That may be better answered by Dr. Schleiss, but to my knowledge, the alternative for testing pregnant women, in some situations, it would be molecular testing for actual DNA, nuclear material itself.
Great, thank you. Dr. Schleiss, do you have any comment on that?
Yeah, no, I would agree. And I think it is much discussed in obstetrical circles, the value of doing PCR testing on women who might have a primary CMV infection. Does that correlate with increased risk of transmission? And I think we just don't know the answer. Women undergo testing during pregnancy for cell-free DNA to screen for things like Down syndrome. It would be very elegant to see these tools adapted for CMV viral DNA testing, but it's still very much in its infancy. I think if anyone on the call is a practitioner who encounters a pregnant person who might have a primary CMV infection, these are appropriate questions to ask in consultation with the maternal fetal medicine specialist.
Great, thank you. Okay, moving on to the next question. What kinds of laboratory tests are used to test for congenital CMV in newborns?
Yeah, well, great question. I think it depends on context. If you're a pediatrician and you're rounding in the nursery and you've got a baby and something just doesn't seem quite right, the baby's small for gestational age, perhaps has microcephaly, perhaps has petechiae or an enlarged liver or spleen. So the baby looks ill and you're suspicious of a so-called torch infection. There's a big differential diagnosis that includes other things beyond CMV, of course, but the sort of gold standard in that setting is to get a urine sample to look for CMV shedding in the urine. I think that's the sort of the sine qua non of diagnosis of congenital CMV. Important that that test be obtained prior to 21 days of age, because beyond that point, CMV shedding can occur in an older infant simply from having acquired the infection from breast milk. Breastfeeding commonly transmits CMV. So if it's the context of evaluation of a symptomatic baby in whom you're suspicious of a torch infection, the urine sample for CMV PCR is the gold standard. If you're asking a different kind of question, which is what about universal screening? High throughput, automated, rapid universal screening for CMV. I've advocated for the dried blood spot simply because we collect it on every newborn anyway as a part of screening for phenylketonuria and maple syrup urine disease and SCIDs and the panoply of diagnoses that we screen for at birth. That's already available. There's no needed additional infrastructure. You just need an extra punch from the blood spot card to run the PCR test. As I alluded to in my presentation, the sensitivity isn't perfect, but in Minnesota, we like to say, don't let the perfect be the enemy of the good. We do have enough information to say that it's a pretty good test with a reasonable sensitivity. And until we can think about other mechanisms to get urine samples or saliva samples on newborn infants, I believe the dried blood spot is the best test for universal screening.
Great. Thank you for that, Dr. Schleiss. Okay, Dr. Prince, this next one's for you. Do you have any information about the clinical utility of IGRA assays for CMV?
So these would be interferon gamma release assays. I do not have any particular information on how useful that might be. I'm sorry.
Oh, great. Thank you. Next, Dr. Prince, maybe instead, is there any value of rising titer of IgG?
Not that I'm aware of. Again, most IgG levels for CMV IgG are measured using an ELISA or some sort of chemiluminescent. And while the value is more or less related to actual concentration of antibody, it's not really a linear relationship. And the only way that you could really use changing in titers would be to do an immunofluorescence assay. And I don't think anybody in the world does those anymore. Within the context of looking at ELISA indexes or chemiluminescent indexes, I don't think there's any real value in looking at changes of that over time and in relation to timing since infection.
Great, thank you. Okay, Dr. Schleiss. Why is it that after all of these years, all drugs used for congenital CMV are still off-label?
Yeah, I don't know. I mean, the FDA is funny about things. I would point out to the questioner that for decades, sick kid with asthma comes into the ER. We give them a nebulizer treatment with albuterol, right? And the most common thing a pediatrician deals with in their clinical practice. And for decades, albuterol was not approved for use in children, right? So, it was technically an off-label use. And so I don't know. I think once a drug is licensed by the FDA, a clinician can use it however she wants in most cases, as long as there is a justifiable standard of care that can be coupled with it. So I'm not particularly worried about it. All I can say is that the regulatory process is sometimes very slow. Ganciclovir has been much discussed for decades now as a potential teratogen and carcinogen, which I don't think it is in either case, although we do not give it to pregnant patients. We do use high-dose acyclovir in pregnant patients. There's never been any demonstration of carcinogenicity or gonadal toxicity in any human who's received ganciclovir, although it is still a theoretical concern and is seen in some animal models. So these may be some of the reasons why it's an off-label use, but I dare say that at least for symptomatic babies with central nervous system disease, ganciclovir, oral valganciclovir is a standard of care, commonly used and probably overused, as I alluded to in my presentation.
Great, thank you. Dr. Prince, what is the best interpretation of the indeterminate result in the report?
You mean intermediate avidity?
I believe that is what our question is alluding to.
It all depends on which trimester the pregnant person is in. Again, as I mentioned in my presentation, if it's within the first trimester, an intermediate result is interpreted pretty much like a high avidity result, which is very low risk of maternal transmission to the fetus. But if the intermediate result is associated with a sample collected in the second or third trimester, the interpretation there is more like a low avidity result with increased risk of transmission.
Great, thank you. Okay, Dr. Schleiss. Next, if there is no good intrauterine treatment, why screen?
Well, I mean, I presume that the question is focused on maternal
Hmm.
screening, and somebody put a link in the chat
Mm.
box regarding Brenna Hughes's study, which did not show any therapeutic benefit for high-dose CMV immune globulin during pregnancy in the context of a primary maternal CMV infection. An important study, and uh, one that has been much discussed. I dare say 15 years ago, we were probably using more CMV IG infusions in pregnant patients than we are today because randomized placebo-controlled studies did not show a benefit. I will point out, however, that the work of Amir and Yves Ville, Ville in Paris, and other places have led to a pretty strong endorsement for high-dose maternal valacyclovir, 8 grams a day, so it has to be high dose, and it has to be given early in gestation. But if there's evidence of a primary maternal CMV infection in Canada and much of Europe and Israel, high-dose oral acyclovir is being used quite commonly now. And so I'm not as nihilistic perhaps about the idea that there's no intervention that can be offered. I think high-dose acyclovir is something that can be discussed with families. And I think also, it's important that a pregnant patient knows what to expect, so that she can make choices and decisions and be prepared. And so I think there's value in identifying these high-risk situations, even if there were no therapy. So I'm a big advocate for a maternal screening in perhaps not universally, but certainly in many circumstances.
Great. Thank you for that. Okay, Dr. Prince, if avidity testing is not approved in the US, can the test be generally ordered or is it sent out to a reference lab?
Currently, the testing, I think, is only performed in reference labs.
Great.
Yeah.
Thank you for that. Let's see. Okay, move on to our next question. Let's see here, one moment. Let's see here. What kinds of laboratory tests are used to test for congenital, or sorry, can you test babies for CMV before birth?
Yes. Well, that's a really important question. And the answer is sure. Amniocentesis can be diagnostic. It's recommended that a window of time be established before the evidence of the primary maternal infection and offering amniocentesis, because if done too soon after the primary maternal infection, you may miss a fetus that will become infected because it takes a few weeks for the viremia to be established and for the transmission event to occur. So those would be issues to discuss with a maternal fetal medicine specialist. But amniocentesis, chorionic villus testing is also a modality that can identify CMV infection at the placental level, and is being investigated in some centers, and I think used clinically in some sites in Europe. Amniocentesis, of course, is a complicated decision to make, and one that should be much discussed before being offered. But there is a solid body of science that corroborates the diagnostic utility of amniocentesis in proving fetal infection.
Great, thank you. Okay, Dr. Prince, do conditions of sample or serum storage and transportation affect avidity tests?
Not that I'm aware of. In fact, when I was at Question, we were validating CMV avidity assays, which we typically did by taking an RUO kit and then modifying it by using some of our own reagents so that we could classify it as an in-house or laboratory developed test. We were using samples that we obtained from the Brussels group, and those samples were 7 or 8 years old, and the correlation was absolutely gorgeous at 100%. What they found is high, we found is high. What they found is low, we found is low. So I think as long as the sample has been frozen, it's totally viable and can be used for your validation studies.
Great, thank you. Are there any recommendations or altered procedures for pregnant people who are immunocompromised?
Well, as far as avidity testing, I mean, if the immunocompromised condition results in low IgG levels, then about the only option you have is the PCR testing of the mom.
Great.
Yeah, I would add that you know there are some case series that have been published on pregnant patients, for example, liver transplant patients with chronic CMV viremia. It is a very high risk situation for the fetus and for the pregnant patient. You know, in some cases, ganciclovir or valganciclovir has been used in those circumstances. There was a paper some years ago from Pescovitz on the use of ganciclovir to prevent transmission in liver transplant patients who were pregnant. Those are really high-risk situations and should be discussed with maternal fetal medicine specialist and infectious disease specialist if possible.
Great, thank you. Okay, Dr. Schleiss, this next one's for you. Seems to be a clinical situation. I have seen a patient, his 1-month baby died due to persistent diarrhea and IgM positive. Now both father and mother are IgG positive for CMV. They want a second opinion. In this case, what is the suggestion?
Yeah, well, I mean, a second opinion about risk for the pregnancy or interventions. I mean, without knowing more details, it's hard to sort of put that into context. You know, second opinions are good. I mean, I think they're healthy, and as clinicians, we should encourage them. I think in this particular circumstance, this would be a woman who should get an avidity test, right? She should definitely have IgG avidity assessment. If she has high avidity antibody and longstanding immunity from her primary infection, presumably with the first pregnancy, then the chances of a good outcome in this pregnancy are high. I always counsel patients that the risk is never going to be zero. And so monitoring by ultrasonography, serologic methodologies, as Dr. Prince described, and perhaps in some circumstances, even consideration of an amniocentesis if there was a fetal abnormality by ultrasound. These are all things worth considering. But, you know, I'm very sorry for the tragedy the family went through with the first pregnancy, but my sense is from past experience that there's a high chance of a good outcome with this pregnancy.
Great, wonderful. Okay, Dr. Prince, is avidity testing used to test for other diseases aside from CMV?
Yeah, the other big one is toxoplasma, because toxoplasma, much like CMV, is notorious for long-lasting IgM, persistent IgM, and so avidity testing is really a crucial part of any toxoplasma workup in a patient that's positive for both IgG and IgM. There's avidity testing for some other viral infections as well, rubella, measles. At least in the United States, you know, those aren't really common tests because those infections are not very common, but they do exist. So,
great, thank you. Okay, Dr. Schleiss, this next one is for you. Have there been any reports of antiviral resistance?
Oh yes, there have, and you know, in a way, I'm surprised. I mean, I'm surprised it doesn't happen more often. Drew, some years ago in an HIV population of individuals on long-term ganciclovir for CMV retinitis, identified resistance rates of, I think, approaching 10%. Of course, that's a very different patient population than the pregnant patient or the child, but the thing they all have in common is long-term use of ganciclovir. I published a paper some years ago on an infant with congenital CMV being treated with oral valganciclovir, for whom antiviral resistance was selected for, and we demonstrated that the mutations that conferred resistance on the virus. I've also seen similar cases in babies born with severe combined immune deficiency who unfortunately acquire CMV disease, and because they have no immune system, they can have a very bad outcome. So resistance does occur. I don't think it occurs often enough with shorter courses of antivirals to warrant, standard testing for resistance in all patients on nucleosides. Only in select circumstances, patient should develop symptoms, or if you monitor viral load and you see a spike in the viral load, then it can be considered. So the answer is yes, it does occur, but less often than you might think.
Great. Thank you. Dr. Prince, I have a more technical question. How do you choose the cutoff for high avidity and low avidity?
So I'm assuming this means when you're validating your assay, how do you set your cutoffs? The trite answer is you find another lab that's already doing the test and ask them to share their samples with you for their high avidity and their low avidity. If that isn't possible, there's a couple of other alternative approaches you can take. And a sample that is IgG positive but IgM negative, with the extremely rare exception, is going to have high avidity. So those would be your high avidity group. And as I mentioned, if you have samples that are IgG positive and IgM positive with a really, really strong IgM signal, the vast majority of those, if not 100%, are going to be low avidity. So those two samples could be used in your testing to sort of set your cutoffs between low, intermediate, and high avidity.
Great. Okay, let's see here. Dr. Schleiss, in case of a positive result for CMV, what are the current guidelines for the management and treatment in both mothers and newborns?
Yes, well, I mean, most mothers don't require treatment for CMV infection if they're immunocompetent. The only exception being if treatment is targeting prevention of transmission to the fetus, as we've discussed, and there is a role for high-dose valganciclovir in some circumstances in that setting. For the newborn, as I alluded to in my talk, I think it is a generally accepted standard to say that a symptomatic baby with evidence of involvement of the central nervous system, either an abnormal neuroimaging study or multiple other symptoms and laboratory evidence of infection with hearing loss, a constellation of signs and symptoms that would move the baby into that moderate to severe disease category, that there is benefit to be obtained from 6 months of oral valganciclovir, as demonstrated by a placebo-controlled crossover study, the Kimberlin study that I alluded to. I think it's less clear whether asymptomatic babies with congenital CMV benefit from antivirals. There are some studies that are ongoing. Most of these have actually not shown benefits. Bear in mind that most babies are asymptomatic and we think have a good prognosis, except for the 10 to 15% that will go on to have hearing loss. And will antivirals prevent the development of hearing loss in the otherwise asymptomatic baby who has normal hearing at birth? It's a question we're asked all the time, and we just don't know the answer. So I think in select circumstances, antivirals are definitely indicated for sick newborns or symptomatic newborns. For the pregnant patient, usually not, unless the goal of treatment is to prevent transmission to the fetus.
Great, thank you. Okay, Dr. Prince. There is a rule that only IgG and IgM, both positive, will give avidity tests. If only IgG positive but IgM negative, they will not test for avidity. Is this a good rule?
Again, this is just my opinion, and no, that's not a good rule. As I presented in my presentation, I think to identify that small percentage of individuals who are G positive but M negative, but nevertheless have low avidity. The best thing to do is to test all IgG positive samples, regardless of whether the IgM is positive or not. One option you might have is if your patient is IgG positive but IgM negative, you then take a further step to look for any confounding suggestions of fetal abnormalities and then decide whether or not to do avidity testing. But if you want to cover the full gamut to identify individuals who might be at risk for transmitting the infection to their neonates, then you should test all IgG positives.
Great. Okay, and I think we have time for about one more question, and I'll direct this to both of you. Are dried blood spots useful for avidity testing, presumably in pregnant patients?
In theory, that would work, but I don't know that anybody has done the experiments to show that that's the case. Dr. Slice, do you know?
Yeah, I agree. In theory, it's a very intriguing idea. It's very hard to get enough, IgG from a punch from a dried blood spot card to really do much with the sample. However, Sheila Dollard at the CDC has published on this, and she's successfully done IgG and IgM testing from dried blood spot cards. I don't know of anyone who's published any data on taking that the next step to look at avidity. Certainly, it's not a test that's available from any clinical laboratory, but it's a terrific idea, very intriguing. And whoever asked the question, if you were interested in pursuing research on this, I'd love to talk to you more.
Wonderful. Thank you. Great. Well, thank you both, Dr. Schleiss and Dr. Prince. It's been a great pleasure to have you both here today. And thank you all for joining us for this webinar. If we were unable to get to your question, we will reach out to you via email. And stay tuned for 2024 as we have a number of other great webinars planned. Thank you all again, and we'll see you next year. Bye-bye.
Bye.